All right, I'm Justine, and today we're going to talk about pediatric congenital cardiovascular disorders. This presentation was written by Leanne Jones and Chuck Skinner. It's got a lot of good information and a lot of big words, so bear with me. So here are just some facts. Approximately 22,000 infants are born annually with some kind of cardiac anomaly. Recent history, there weren't any surgical interventions for these defects, and about 60% of all infants died in early childhood because of their congenital heart defects. But research and surgical interventions have really, and now there are tons of things that they can do to combat that. So here are just some of the objectives for this particular presentation. We're going to look at the normal cardiac anatomy versus congenital anomalies. We're going to look at the differences between the 4 types of cardiovascular disorders, though I believe there are a few more in there. And then look at some different assessment tools, which I'll go ahead and tell you now. We're going to kind of breeze through those because the majority of them are the same. And then we can discuss treatment modalities and some of the long-term effects or the outcomes for the pediatric patients. So let's see. So A&P of fetal circulation, basically this is talking about in utero. The mom and baby are going to be sharing a lot of the blood. So anything the mom does, that's going to be as far as whatever she's taking into her her system, it's going to get it to the baby. The fetal lungs are not used to oxygenate blood yet. That's going to be after they're born. There are different purposes and functions of things such as the foramen ovale and the ductus arteriosus, and we'll talk about those a little bit later. And then there are a few anatomical changes that take place at birth. So this is a typical fetal circulation. And then we'll just talk about normal anatomy. The heart's divided into 2 sides by the septum. We should know that. It's no different than an adult. And then again, it's divided up in each of those. That gives you a total of 4. You have 4 valves and different functions of arteries and veins. And then there's also a normal blood flow pattern in which it follows. This is a normal pediatric heart, not much different than the adult heart. And this is also where you'd auscultate, again, not different. There are 4 types of cardiovascular disorders. There could be heart defects causing extra blood through the lungs, blood flow through the lungs, anything that causes an obstruction to blood flow, or different complex heart defects, which could be a mixture of the various ones. So the ones that cause extra blood flow through the lungs, you're going to have your PDA, or your patent ductus arteriosus, an atrial septal defect, or ventricular septal defect. And if you think about the anatomy again, you can see where that could be a problem, causing extra blood flow through the lungs based on where the defect is in the septum. So a few statistics as far as with your PDA, there are about 1 in to 5,000 full-term live births. It occurs 3 times more in females than in males. A lot of these disorders happen more in females than in males. It's the 6th most common, and we hardly ever see it. Here, let's go back to that real quick. The main thing to remember about this one, it's going to be left to right shunting. So think about what your patient's going to look like if they're having left to right shunting with the PDA. And so this is how the anatomy is different. So right up here, we have this little area that has not closed off. So in normal anatomy, it would have closed, and you have two separate entities between your pulmonary arteries and then your aorta. But here it hasn't. So you've got your oxygenated mixed with blood that has not been oxygenated. So their clinical presentation, which is, they aren't always symptomatic. It just depends on the size of the leak. If you have a very small one, it's not going to be as obvious as one that's larger. They would have a persistent murmur, and that will be at the left upper sternal border. They could be tachycardic. Again, that's going to be hard to tell just because infants are typically tachycardic anyway, and so they may go around and around thinking about, you know, what's going on, what's causing them to be tachycardic and tachypneic. They would have a wide pulse pressure. Sometimes they have prominent bounding pulses, but the main thing to remember with these kids, well, a lot of them that have cardiovascular defects, they're going to be really tired when they feed, because if you think about it, while they're feeding, they aren't getting as much oxygen anyway. And then they're having this issue with where their oxygen's going. So some diagnostic tests, and you'll see this over and over and over again in this presentation. You're going to get the chest x-ray and EKG. They may do a cardiac cath. They could do Doppler color flow mapping or an echo. So this is the color Doppler, and it just shows that there's a mixture between oxygenated and deoxygenated and where it's at. So initial supportive care, just monitor your patient. You're going to give them oxygen to correct hypoxemia, but it's very important that you know what congenital defect the patient, and if you should give them oxygen or if you should just kind of withhold a little bit of it, because some of these defects are going to be similar to that of an adult. Like say they have COPD, it'll be similar to that. If you're giving them this oxygen, then their drive is going to pretty much shut down. They're going to be dependent upon you giving them oxygen rather than us fixing the problem. They're going to be on fluid restriction. It's not going to be much different than a heart failure, and a correction of any anemia, because remember, the blood's not getting where it needs to go or as it typically would. Some treatments, you can do a diuretic initially. They can have digoxin, but just not in premature infants. You could do prophylactic antibiotics, and that's going to be more if you plan on taking them to surgery. Definitely the coil closure, or they could do a ligation depending on the surgeon and the case. So this is one of the ligations. I'm sorry, ligations. And then a coil closure. They just take it in. It's no different than any other coil closure that they put in. They just wrap off that area, and then it separates it into two entities back to the aorta and the arteries. So again, a lot of these patients present the same. They're going to be tachypneic, possible respiratory distress, again, depending on how large the area is. And they may have some ectopy or, again, a murmur. Their color may be a little bit pale. They may not be perfusing as well. They could have a decreased LOC, which is, again, is very difficult to measure in an infant. But they won't cry as much. It'll tire them out. They may not feed as well. Some interventions, just make sure you're keeping up with those assessments and reporting any changes. Monitor the side effects of any medications that you give. You could give them some pain management because it is just a little bit more difficult for them, and do infection control. So our next defect, the atrial septal defect. So this is going to be 5 to 10% of all cardiovascular congenital defects. And it's, again, it occurs more in females than it does in males. The patho behind this, it's going to be an incomplete formation of the atrial septum. They have left to right shunting, and this is going to cause the right ventricle volume overload and increase pulmonary blood flow. It's very important to remember. So this is what it looks like. Okay, right here you have this guy's closed off, your septum, and then here it's open. So again, you're having the same kind of deal, except it's a larger area that's being affected. Again, they aren't always symptomatic. It depends on the size. If they have a small tear or a little leak, as opposed to the whole septum having a defect. They'll have the systolic murmur, left sternal border. They're going to tire easy, tachypnea. They could be diaphoretic and have a large, they could have hepatomegaly. Again, same diagnostic studies, the x-ray, same as the last one, the EKG. They could potentially do a cardiac cath and an echo. And this is what it's going to look like on the chest x-ray. And this would be if they did the ultrasound or the echo. So some of the treatments, about 80% of the smaller ones, they could close on their own after the first 18 months. And then if they aren't closed by the age of 3, then there must be that takes place. Again, same thing, since it's causing a like a pseudo heart failure, you're going to treat it exactly the same. So do your diuretics, make sure you're doing your antibiotics, prepare for open heart surgery, or they could do the Amplatz or septal occluder. So this is going to be the surgical repair. And this is going to be the Amplatzer that they can insert. They put it in just like any kind of balloon procedure. It goes in, spreads open, blocks off. It's a mesh. It'll help with clotting. The assessments you take, same as any other congenital heart defect, or same as any cardiovascular assessment that you're going to do on any patient every single time. You know, watch for respiratory distress. Note their rhythm, their rate, and any ectopy. Always make sure you get an EKG. That's very, very important. For those murmurs, monitor their LOC. Again, it may be a little bit more difficult in a child because they want to sleep all the time. If they aren't cooing and waking up and interacting, then the problem. Some interventions, just continue your assessment, effects of medication. You can do pain medication again. Monitor your invasive lines and any drainage systems that they have, and always infection control. And then we have the ventricular septal defect, which is the most common, and this one you could potentially see as far as our pediatric transports. It's definitely the most common. It's about 20 to 30% of all heart lesions, and it's one of the most common with Down syndrome. It affects males and females equally. In the patho of it, you have an incomplete formation of the ventricular septum. So you have left or right shunting. Typically it's muscular. It causes right-sided volume overload and increased pulmonary blood flow, again. It could eventually lead to an increased PVR, causing reversal of the shunt. So you would definitely have cyanosis. This is what that looks like. So down here, you have your septum again. You don't here. So now you have a backwards flow of blood, again, causing the same thing, the mix of the oxygenated and not oxygenated blood. So their clinical presentation, again, depends on the size of the shunt and the degree of pulmonary hypertension. They're going to have a pansystolic murmur. It's going to be in the left lower sternal border, very loud. They're going to tire way easy. They're going to have poor weight gain. You may see them in respiratory distress. That may be the first indicator. And that will typically be what you think of whenever you see these kids. They have a lot of respiratory issues, respiratory infections, CHF, and hepatomegaly. They do the same thing. Cardiac cath, chest x-ray, echo, EKG. Those are super important. Just remember those for any of our cardiac patients, especially pediatrics. The 4 things: the chest x-ray, echo, EKG, and cardiac cath. And that's what it would look like on x-ray. So here's a good image of the opening of that wall between 2 ventricles. And that's what it would look like. So the treatment for this one is a little bit different. You can do dopamine, and that's just going to depend on the patient. This is not a definitive treatment for VSD. It's going to be how they present. You can do your isoprel. They do banding a lot of times on this issue, but the majority of the time the kid just has to go in for open heart surgery. So this is what banding looks like, where they just band the 2 areas together. And then this is where they take the band and wrap it around and occlude that area. And here's a patch that they put in sometimes that eventually helps it just kind of scar over, grows over on its own. The assessment of these patients, again, same thing. Tachypneic respiratory distress. They're going to appear to be in fluid overload. Always note color, perfusion, pulses, rate and rhythm, their LOC, but for sure the color and perfusion is going to be a huge indicator on these kids. Some interventions that we would do: continue to assess, as always, monitor the actions and side effects of the medication. You can do pain medication, monitor your invasive lines and any drainage systems that they have, and infection control, always, always. So now we're going to talk about heart defects causing too little blood flow to the lungs. We've got pulmonary atresia, transposition of the great arteries, and tetralogy of Fallot. So your pulmonary atresia occurs in like 8 per 100,000 live births, so it's not very common. There is not a genetic link noted to this abnormality. Your pathophysiology of pulmonary atresia: failure of the pulmonary valve to form. Blood can't exit, so you have right to left shunting through the foramen ovale. And then blood's only going to get to the lungs through the PDA. And then if the ventricular septum is intact, your right ventricle will be hypoplastic, and you could have a stenotic tricuspid valve. So this is what that looks like. You have your normal, and as you can see, the blood flow is just extremely confused onto where it's going, right? Their clinical presentation: they'll be a tad bit lethargic, a little bit irritable, tachypneic. They're the most important one to remember about this: periorbital, generalized cyanosis if the PDA has started to close, and they'll have that pansystolic murmur as well. And that can be heard the 2nd or 3rd intercostal space. So until surgical intervention, this is the guy that you want to keep that O2 kind of low. So deprive them, because if not, you're going to close the PDA and then potentially kill the patient. So keep your O2 to a minimum just to keep the sats around 85%. That sounds low. They live, so this should not frighten you. This is what they're used to, and by depriving them of that, you're keeping them alive. You're going to want to keep their BP up. Start prostaglandin drip if possible. They may need vasopressors if in shock. And typically, these are really, really little guys. So a lot of times if the hospital has their own transport crew, they'll send them or people like the kangaroo crew. We don't see a lot of these. These are very young, and you have to catch it super early. This is going to be your blue baby. So I'll just read the definition here. A blue baby is an infant born with a congenital heart defect. The defect prevents oxygen-rich blood from circulating to the body, which gives the infant that bluish tint because they aren't getting the oxygenated blood. Again, same diagnostic tests. Your treatments, that would be your prostaglandin, and that's going to be if somebody has initiated it already. For palliative care, you can do the Rashkin septostomy. I'm not familiar with that. I'll just be honest, but they do that prior to us arriving. What we're used to would be the surgical interventions or the medical interventions prior to the surgical interventions. We may even have to take care of a kid after they've had the procedure or a valve replacement, this issue. And then this is the ballooning that goes straight through. It's similar to the mesh that we saw for the previous congenital anomaly. So and this is how it's inserted. It goes straight through, balloons up, and as you can see, it would block that area. The Blaylock shunt. This is what they usually do, though. They don't do necessarily the porcelain valves anymore as much as they do the mechanical valves. The mechanical valves they just last forever. Blood flow remains really good. Some disadvantages is that they have to be on Coumadin for this, so they would have to be monitored, and they have a few activity constraints. However, if you're comparing the two, the porcelain valve has to be replaced. The mechanical valve, not necessarily. So it's usually what the surgeons put in. So the assessment of this patient, exact same as all the other ones. Watch for respiratory distress. Watch your LOC, color, perfusion pulses, rhythm, rate, and ectopy. Some interventions post-op, they're going to be the same as any other post-op patient that you have. You're going to continue your assessment, report any changes. Do not do a blood pressure on the affected side, and that's for pretty much any surgery that they have, that anybody has. You don't want a blood pressure on the affected side. You don't want to mess with any of the shunts or anything like that. Definitely pain management, because even though they're little, they are hurting. Monitor your invasive lines, your sites where the surgery took place, and watch for infection. Maintain, a lookout for infection control. All right, so next one will be the transposition of the great arteries. So it's the second most common congenital cardiovascular disorder. It's going to be occurring in 5 to 7% of all congenital heart defects. Super common. Okay, so the patho of this, the aorta and the PA arise from the wrong ventricles. This is going to cause systemic and pulmonary circulation to be parallel rather than in a series. So they must have some place where blood can mix, and that could be various locations. So as you can tell, it's a mess. It is a mess. They're going to be diagnosed within the first few days of life because they will remain cyanotic. Typically, after a child's born, they only remain cyanotic, I would say up to a few hours, and then that should resolve. But these kids, they never lose that. They're going to have a low PaO2, which keeps your ductus open. They're going to be comfortably tachypnic, so it won't be labored. They're just going to be breathing excessively. They could have a murmur, and they would be tachycardic. For diagnostic tests, they could have the hyperoxia test, and then the other test, the EKG, chest X-ray, echo, and cardiac cath. And that's what these guys look like on an X-ray. Again, with your echo. The treatment, prostaglandins. Monitor your invasive lines. Make sure any of the lines that IV tubing. If you're doing invasive blood pressure monitoring, no air in the lines. Open heart surgery for atrial switch or an arterial switch usually happens in the first 2 weeks of life. So it could be super stressful. So just remember that for the patient, the parents, everybody that's working on that team, way stressed out. Okay. So these are examples of the different switches that you can do, or that can be done, that the surgeon will do. Again, same typical assessment. You're going to watch their respiratory effort, their rate, and then cardiovascular rhythm, rate, and any active beat, any LOC. You also want to watch the temperature in these kids, just to make sure that they aren't getting more sick, especially after surgery, because this is typically found early on. So they go to surgery fairly quickly. So infection would be a huge factor for these kids. In your assessments, monitor action and side effects of any medication, infection control, and monitor invasive lines. And then you have your tetralogy fellow, and it is equally distributed among males and females, and it occurs in about 10 to 15% of all cases of congenital cardiovascular defects. The patho of this, so tetra is 4, so 4 defects. You have your VSD, pulmonic stenosis, your overriding aorta, and right ventricular hypertrophy. So remember, tetralogy is 4, right? So the pulmonary limit the blood to the lungs. Your VSD and overriding aorta allow unoxygenated blood to return to the right side of the heart and to the body. Hypoxia is a huge issue for these kids. So as you can see, it's quite a mess. They're going to be super cyanotic. They could have clubbing of their fingers, failure to thrive, decreased activity tolerance. And there is a position that a lot of these babies like to assume that it kind of helps with being so hypoxic and getting some oxygen. They could have hypercyanotic spells. They're called TET spells. They're going to have a marked increase in cyanosis, irritability. There are different treatments in this position is what I was talking about. The knee to chest position to reverse shunt to left to right, O2, is little to no help. So that position really opens everything up. It shunts the blood so that it's not going anywhere else where it needs to be so that they can breathe easier. It's a TET spell or hypercyanotic spell. And this is kind of what they look like. That's a little bit of an older kid to have tetralogy of Fallot. They typically find it a little bit earlier with your little blue babies. Again, same studies. They may do ABG, though that would be the only difference in this kid. So chest x-ray, echo, EKG, and cardiac cath. And this is what it looks like on the x-rays, on the echo. And this would be a typical EKG of a baby with tetralogy. And some treatments. You can do oxygen. Again, it's not super helpful, but it doesn't hurt. Diuretics, Inderol, you can do digoxin, and morphine's going to help a lot. The surgical treatment is going to be different types of shunts or open heart surgery for total repair. And a lot of these kids, that's inevitably what they're going to get is open heart surgery. So these are the two different shunts. You can have a modified shunt as on the right, or you can have the Blaylock tossing shunt that's not modified. Okay, this is what it looks like repaired. Assessment, again, it's going to be exactly the same. Watch for the same thing every single time. and you can't go wrong. So watch for the respiratory distress, the color of the perfusion, pulses, any bleeding, rhythm rate, and again, if they've already had that surgery, monitor the site. Interventions are typically the same. Continue your assessment, report any changes, especially cyanosis. If they become cyanotic again, there's another issue going on. Action and the side effects of the medication that you've provided. Provide pain management, watch invasive lines, infection control. They do not get a blood pressure or venipuncture in the shunt arm. Again, neither does anybody else. So now let's talk about heart defects causing obstruction of blood flow. That would be your cortication of the aorta or aortic stenosis. Your COA, I'm just going to shorten that, it's going to account for about 10% of congenital cardiovascular defects. Males are twice more likely to be affected than females. So males have more of the blockage, whereas females have more of the shunt formation issues. So the path of this, they're going to have a narrow segment in the aorta, and it's usually after the arch. One of the theories is that there's extraductal into the aorta, which will narrow it. And it's going to cause decreased blood flow to the lower half of the body and extremely high pressure to the upper parts. So if you can see that as like a straw, and the straw turns into a cone type closure almost. So it's going to be harder to get that blood through there. So if you think about it that way, they're going to have that decreased blood flow to the lower half of the body, and then high pressures to the upper parts. The LV stress trying to pump against narrowing, causing CHF. So this is what that looks like. So you have a normal aorta, and then here you have the narrowing. Their clinical presentation, they're going to have unequal blood pressures between upper and lower extremities, hypertension in upper with diminished or absent pulses to lower extremities. So that's super important to remember with this one, the unequal blood pressures, but between upper and lower extremities. And then which one is going to be higher or lower. They're going to be pale, diaphoretic, potentially tachypnic, and poor feeding. They're high risk for aneurysm, and you can definitely see why that could be an issue. And for sure, spontaneous hemorrhages, because there's so much pressure on that wall that eventually they're going to weaken. It's just like an adult that has an aneurysm. They're trying to compensate by having that extra pressure build up, but over a long period of time, that pressure could cause detriment to those walls that are very weak. Again, the diagnosis is the same. This is what we look like on an x-ray. And then here we are with the Doppler. Some of the treatments for this are a little bit different. You can do nipride, Inderal. They could have the angioplasty, anastomosis, or a patch graft. A lot of different kinds of grafts. They try to surgically remove this area. So let's look at that. This is the area where that extraductal tissue potentially resides, where there's that narrowing. So they're just going to take it out, and then they have the anastomosis where they just put it back together. And then this is what it would look like if they had a flap. They just take that little guy out. So the assessment for your post-op patient, because that's typically when we're going to see these patients. Watch for movement of lower and upper extremities. It says lower here, but both. Monitor for hypertension or respiratory distress. They could potentially show signs of abdominal pain. Hemorrhage is a huge deal. And again, any type of symptoms that you would note in a patient that has an aneurysm, you would also watch for in these. Infection control remains to be a huge issue. Some interventions: continue your assessment, monitor, note the side effects of the medications as well as how well they worked. Pain management for sure. Monitor your lines, infection control, and remember pressures or venipunctures in the arm where the subclavian flap was used. Next is aortic stenosis. That's going to occur in 3 to 6% of all congenital cardiovascular disease. 4 times more likely in males than females. Again, males have a higher instance of this blockage, whereas females, it's more congenital defects as far as like septum formations. So the pathophysiology, you're going to have the inability of the aortic valve to open completely. The LV must pump harder to force that blood forward. Coronary arteries may not receive adequate blood supply. So this is what that looks like. So that little flap's got to work real hard. The clinical presentation, same as all the rest. They could potentially have a murmur. Tachycardia, palpitations. And then this is what this looks like. So the normal tricuspid aorta, and then here if they have thickened leaflets, and then a bicuspid with thickened leaflets. So these guys, they're going to have the chest x-ray, echo, they could do a treadmill test. So that's just going to be where they're under stress. They monitor how well that their blood flow is under stress. So this is an x-ray image, and then we've got our Doppler. They could do a valvoplasty, valvotomy, aortic valve replacement, hemograft, and that could be aortic or pulmonary. The pulmonary one's also called the Ross procedure. And this is just the plasty. They go in, open it up, and this is what it looks like. So it improves the blood flow through any kind of narrowing valve with the catheter. So it goes in and then it's inflated around the leaflet. You could just make a surgical correction of it with the valvotomy, and they just go in, cut a little area where it's stenotic, and try to make it normal again. It's a valve replacement. The Ross procedure. So the pulmonic valve is replaced with the healthy valve from the assessment is going to be the same. Monitor for hemorrhage, tachycardia, respiratory distress, tachypnea, rhythm rate, ectopy, same. Interventions, exactly the same. You want to try to encourage a high caloric intake for these patients, and infection control as well. Then we've got complex congenital cardiovascular disorders. So you've got your truncus arteriosus, or your TA, and then we've got total anomalous pulmonary venous return, hypoplastic left heart syndrome. So it's going to occur in only 1% of all congenital cardiovascular diseases. It's equal in both male and female. So you've got failure of the embryonic truncus to divide into aorta and the pulmonary artery. So your unoxygenated blood and oxygenated blood mix in the ventricles through the VSD. Some blood gets to the lungs and some goes to the body. It's going to cause varying degree of cyanosis based on how large the area is and how much blood's getting to that area. And this is what it looks like. So they never actually fully separated the aorta and the pulmonary artery, right? So these are the different defects. I can't move those over for you, but the clinical presentation, they could be cyanotic, they could have an ejection murmur after the first heart sound. They'll have bounding pulses with wide pulse pressures, and they're going to have poor feeding and fatigue. Same diagnostic tests as previous. what we look like on x-ray. This is what we look like on ultrasound or echo. Your treatments are going to be your ACE inhibitors, diuretics, but definitively open heart surgery. And this is going to be a repair. So they just go in and give like a patch or try to close that area. The assessment, same, exact same. Interventions, again, same, and you're going to encourage high caloric intake. And then this guy, the TAPVR, so the longest name, right? It's super rare. It's equal in males and females. The patho behind it, pulmonary veins don't connect with the arteries, but instead they drain into the right atrium by way of a connection, okay? And then they have shunting. There are 4 types. So supra cardiac, a cardiac, infracardiac, and a mixed. So that could be any of the previous named. So longest one, biggest miss. These kids, a lot of times they'll have grunting. It's so hard for them to breathe and to work. Their body is literally exhausted. They're going to have a low O2 stat. But again, you don't really want to load them up with oxygen. You kind of want to have that just permissive, just because that PDA can close and then there's nothing we can do. And that's a little baby that has that. The initial support, you're going to consider prostaglandins, support for their keep sats, try to keep them above 80 and correct any anemia. Digoxin, they could have an ECMO and open heart. So this is the little ECMO circuit with your O2 blender that goes directly into the patient. There are tons of complications, as we know, of ECMO. That's why a lot of physicians, they go ahead and do that open heart surgery just because, I mean, you could get infection, blood clots, transfusion reactions. They could have ruptured tubing on the ECMO, so that could cause blood loss or air embolus, and that would just kill the patient. Here is a wonderful little ECMO we have here, little pump. Same assessments, and then same interventions. Your hypoplastic left heart occurs in about 8% of all congenital cardiovascular disease. It's one of the top 3 defects to cause problems in newborns. It's most often in males. So most structures on the left side of the heart are small and underdeveloped. Right ventricle must do the work of both the right and the left side. This is going to result in mitral and aortic stenosis or atresia, hypoplasia, ascending aorta, and aortic arch. The PDA and foramen valve by time till closure to help oxygenate the body, but once they're closed, this is not a whole lot anybody can do. So this is what that looks like right there. They're going to be cyanotic. They're going to have O2 sats in the mid to high 70s, weak pulses in all extremities because they're not really getting any blood anywhere. So again, potentially prostaglandins. I don't see calcium given a lot. You can consider vasopressors. That's gonna be based on the patient. Keep sats about 75 to 85%. Monitor for any apneic episodes. Definitely keep correct any anemia, sedation, analgesia. Try to balance road, but long term, these kids are going to have a larger intervention than that. Diagnostic tests, the same. That's what they look like. So your prostaglandins and your diuretic, and you don't want to give O2 to these kids. Remember, 75 to 85. They could do the Norwood procedure, bidirectional Glenn shunt, depending on the stage of what's going on. The Fontan procedure, and yes, and just remember, O2 is not our friend. They inevitably need the heart transplant, a heart transplant. So this is going to be your Norwood procedure. That's going to be trying to repair the aorta. They could do the modified Blaylock. They're going to need a lot of interventions, remember. So they're going to be real sick for a long time. This is the Fontan procedure. So the first stage is going to be that bidirectional Glenn, and then the second one is the Fontan. So the graft reroutes the blood to bypass the right atrium, goes from the superior vena cava directly to pulmonary artery and then the lungs to pick up oxygen because they're not getting that oxygen. And then they with the Fontan for the blood to go back. The blood flow from vena cava to the pulmonary artery. This is going to be mortality by age, as far as like a wait list for the candidate that needs the heart transplant. Then these are some of the heart post-transplant patient survival by age statistics. So they aren't fantastic, but the earlier they can get it done, the better. Again, same assessment, and then your interventions, pretty much the same, right? Pain medication, invasive lines, infection, your medications that you give, and a continued assessment. All right, what medication would be utilized in pediatrics that accelerates closure of the PDA? And we should all know this one because I said it about 6 times. Oxygen. The other drug that's used to close your PDAs, that's going to be indomethacin or Indocin. A common primary complication of PGE1 is that would be apnea. And then your PGE1 is indicated to keep the PDA open. And then this is just a funny little thing that was added, the top 10 signs you're in a bad hospital. I'll let you pause those and read those later. The number 1 sign you're in a bad hospital. Okay, and that is the end of that presentation. So, not too bad. We're all done with that. Thanks, guys.